So to kick off this series, it is an honor to introduce Dr. Mary Wu. Dr. Wu is highly accomplished. She's currently a professor in the UCLA School of Nursing. She served as Associate Dean from 2001 to 2006. In her current research, which is vast, she examines predictors of sudden death risk as well as the influences of sleeping hemodynamics on heart rate variability and mortality in heart failure. She's currently a principal investigator on 2 NIH R01 grants and co-investigator on 3 NIH R01 grants, if I'm correct.
We're now at 6.
It's 6? Oh, wow, 6 NIH R01s. Oh, my goodness. She's phenomenal. Dr. Wu presented the 2013 National Institute of Nursing Research Director's Lecture and was recognized as a pillar of cardiovascular research by the American Heart Association Council on Cardiovascular Nursing. So please help me welcome Dr. Mary Wu.
Hi, I'm so happy to be here. Particularly, I see so many familiar faces. I'm thinking, oh, yeah, they could. This kind of demonstrates, number one, that my students do survive. I do not completely eat all of my young. Number one, and number two, they've listened to this and heard me say the same thing over and over again so many times that they could probably give this lecture as well. But I think I need to emphasize, why do we care about power analysis? Why do we even worry about experimental design? It's because it's not as if everyone has that much time to do a study. I mean, it takes a lot of effort and planning. But I have to admit, I'm one of those that I always start off my research with going, can I actually do this? How many subjects do I really need in order to answer this question? And that's because I didn't get this fat working that hard, okay? If I sat down and it turns out that I needed one of my studies needed like 400 subjects in 3 years, I don't think I'm going to be able to do that. So why would I spend so much time writing up the grant or the project? Now, I know a lot of people say, I have to admit, a lot of my physician colleagues, I do a lot of work with the cardiac fellows, and they're always coming to me and telling me, we need 10 subjects. I'm going, how did you come up with that? Okay, well, 10 sounds like a good number. Well, it's not a good number. It depends on how often the characteristic occurs, how big of an impact, or what we call effect size, and the like. And that's what I'm going to talk to you about here today. So why do we know about statistics or power analyses? Well, remember, if we just simply say it's my opinion that this works, then you're fighting against somebody else's opinion. Statistics is a quote-unquote objective way of demonstrating whether or not your hypothesis or what your supposition is correct or not. All right? So it's a way of taking out the individual my opinion versus your opinion kind of thing, and just objectively saying, don't blame me, blame that math equation. Okay? Next, power analysis provides the user with, number one, the ability to know how many subjects are needed for a study. So that's what power analysis, that's all it is. It's like, what's the minimum number of subjects you need to do that study? So it helps you plan in terms of how many subjects do you need, how many resources, and the like. It also provides information regarding how much impact a variable may have on the problem or clinical situation. Being clinical myself, I always have, of course, the infamous drug reps come up over here and go ahead and thrust all these, what I call the glossy paper glamour, all those reprints, right? And they say, look, you guys have got to put this drug into your formulary. And I look at it, I'm going, okay, this will change mean blood pressure by 1.5 millimeters of mercury. They're going, look, it's statistically significant. But I'm going, that's not very clinically significant, right? So we have to remember there's statistical significance, but there's also clinical significance. And you need to have a good knowledge of what you figure would be a clinically significant problem, and then figure out, is that effect size really that important? Now, when you're doing a research, I mean, I guess there's really many different ways of doing research. One is what I call data in search of significance. I used to work with Bill Stevenson and Lynn Stevens here, cardiologists, and that was their way of doing research. You know, basically, I would say, okay, you know, you're dealing with heart failure. What do you want? They said everything. Okay, so they would grab all data known to humankind. I spent my lifetime down in medical records, okay, getting this data. And then we'd throw into statistical analysis packages, and we just sit around and pray that something would come up statistically significant. Now, that took a huge amount of time, and with me spending my lifetime down in medical records in the hope of what I call the statistical fishing technique. I think a more efficient way is for you to come up with a hypothesis. In other words, where you know what is the target population, what are the characteristics of that group, right, that you want to study. And remember, the more homogeneous, the better. What is the independent variable? In other words, what do you think is going to make the change, the dependent variable, the outcome variable of interest? It could be survival. It could be patient satisfaction. It could be decreased infections. That's the dependent variable. That's your outcome variable. But your independent variables, what do you think, if you manipulate that, is going to change or impact your outcome variable? Okay, so you need to have those clear in your mind. I mean, hypotheses or research questions like, what's going to change happiness in my patients? That's a little too vague, and it will take you your lifetime to figure out, right? So the more specific you are and be able to define what is your independent, remember, that's the thing you're going to manipulate. That's the thing that's going to cause a change, and how to define and measure your independent and your dependent variable also known as your outcome variable. What you expect, like I said, it could be patient satisfaction. It could be infection rates for, Foley catheters. It could be something like quality of life in post-transplant patients. So what your outcome is, the better you can define these and know how you measure them, the easier life is going to be. Okay? The other thing is, what do you think is the direction of the relationship? So if you apply that independent variable to that outcome variable to the dependent variable, how big of a change do you expect to see? For example, are you going to, like if you give my favorite example, the Woo Wonder drug, the heart failure patients, right? A large impact would be like 50 or 80% improved survival in comparison to the people who do not get the Woo Wonder drug, right? Or instead, it might be a half hour improved survival is a pretty small effect size, right? So again, remember, the bigger the effect, in other words, the bigger the impact that you expect to see with those variables, the smaller number of subjects you need. Does that make sense? So again, bigger the change you expect to see between your groups, the smaller the sample size. However, if you only expect to see, like, for example, on student tests, I have a 100-point test, the difference would be very small. It'd be like 98 versus 99 points. That's a pretty small effect size, so you need a big sample to be able to detect that. Okay? So again, what you would want to do is, number one, identify your hypotheses and be specific in terms of what is the target population, what is the independent variable, and how are you going to measure it, what kind of units is that, right? What is your dependent or outcome variable, how are you going to measure it, what are the units going to be, right? And then the direction of the relationship. You also then need to then identify what is statistical test. Now, every time I start talking about statistics, I start seeing people's eyes like wander around. Gee, that ceiling tile looks really, really interesting. Because a lot of people, for some God knows what reason, are afraid of statistics. As soon as we start talking about it, people start to quiver. But, I think particularly for those who have taken my class or heard me talk about this, I actually have a chart on how to select statistical analyses. Because when you come right down to it, for bivariate analyses, there's not a whole lot of choices. In other words, if you're just looking at one dependent variable, there's not a whole lot of choices. So, I can go ahead and give to your group here. Just email me to remind me, and I'll email you this chart. So it's just where you would just follow. Okay, here's how many groups you have. Here's the kind of data your independent variable is. Here's the kind of data your dependent variable is. Presto. There's your statistical analyses, and I have it for both parametric and non-parametric tests. Parametric tests are those in which the data is normally distributed, which is very, very rare in biologic data, and non-parametric tests are where the data is non-normally distributed, in other words, without that bell-shaped curve distribution. And that's actually much more common, but you'll notice most people don't use non-parametric tests because they're not familiar with them. But that's why God created stat packages, to do it for you. Okay? Next, then, you need to calculate out your sample size, and this is where power analysis comes in very, very handy. So first step, remember, is to identify exactly what do you plan to do in terms of what are your hypotheses, your target population, independent variable, right? Then identify what kind of stat tests you plan to use. And again, you can use what I call the Wu decision tree for statistical analyses. And then from there, you can go in and do a power analysis, say, how many subjects do you really need to answer that question? Now, one of the important things is to be able to select a good hypothesis, okay? If you have just something very vague, the purpose of the study was to demonstrate that there is a positive correlation between vitamin E intake and incidence of lung cancer in adult cigarette smokers, that's pretty different. I mean, that's pretty specific, right? Whereas you say, is there a difference in compliance to medical therapy in adolescent diabetic patients whose primary healthcare provider is a pediatric nurse practitioner or a pediatric specialist physician? That's kind of good. But if you look at the third one, is pregnancy a safe option for females who have undergone heart transplant? Well, how are we defining safe? Right? Is for the females, are these individuals who it's their primip? Or have they had children before? That's going to make a big difference, right? And plus their age and the like. Okay? So when we talk about type, now one of the things that you're going to have to do in order to select the correct statistical analysis is to figure out what kind of data do you have for your dependent variable. All right? Now, I kind of broadly categorize data types into categorical and then continuous. Categorical includes nominal kind of data like, eye color, hair color, gender. In other words, you can't really give them that one is superior to another unless it's gender, and then I'd say females are superior to males. But, under normal circumstances, you would not they're not given a numerical value or in terms of precedence. Okay? Ordinal, this is where the data cannot be given a direct numerical value. In other words, that would be equal in units between each other. It's kind of like ranking in a beautiful baby contest, right? This baby one is number one place, but that baby in the number one place is not 3 times more beautiful than the baby in the number 3 place. Okay? They're just rank ordered, but it's not necessary that there's any strict or constant categorization or amount of distance between these categories, okay? So, for example, we may put people in alphabetical order. That's another example of ordinal data. But the W's, like woo, right? I'm not, 8 million times less, well, maybe in height, maybe I might be, than some of the people in the A's, right? And then there's continuous data. So anyway, everything in categorical data is usually having to be evaluated with non-parametric statistics, right? However, when we look at continuous data, then there's interval and ratio data. And this is where the data can be assigned direct numerical value, so the units are identical rank and order can be assigned, but the only difference is that there's no meaningful zero. Okay? The classic example is, for example, in degrees Fahrenheit. Right, you know, if we were just standing around outside and holding a glass of water outside, we could never really know when it was 0 degrees Fahrenheit. However, if we use degrees centigrade, that is, in fact, has a meaningful zero, and that's why it's called ratio data. Because if we're standing outside on a cold day with a glass of water at 0 degrees centigrade at sea level, water will freeze. Right? So everybody can say, oh, look, water's freezing at 0 degrees centigrade. We can never do that with degrees Fahrenheit. Does that make sense? But for example, interval and ratio data are kind of similar because something that is 10 pounds is twice as heavy as something that's 5 pounds. In other words, the unit names make a difference, and they have a distinct and constant value in between the units. Okay? Now, what is the data type? Then, you know, for example, if there's different salivary pH, again, pH has an actual meaningful zero, and it's continuous data, right? Does nursing intervention X reduce the fear of side effects to condition Y? That's probably more categorical data, right? Probably ordinal. And is there a relationship between the level of depression in clients of type X and the amount of sleep medication? Now, amount of sleep medication could be 0, or it could be 200 milligrams, something like that. So the units will make difference. That's probably more continuous data, right? So this is one of the statistical way you can pick out a stat test. And this is from the infamous Paul Hungler nursing research textbook, which, you know, you can get in the biomedical library and all that kind of stuff. Basically you pretend you basically say, okay, here's the kind of data you have for one variable. Here's the kind of data you have for another variable. You have two groups, parametric versus non-parametric tests. And so, for example, say I wanted to see is there a difference in age between heart failure and my control groups. Well, age is a continuous variable, so we could probably use parametric statistics. There's two groups, heart failure and controls. And so we would say, hey, guess what? I can use a t-test. Okay, so this is from Paul Hungler, which, like I said, is available in the library. If you email me, I can send you the table if you like this better. Here's the Wu bivariate statistical test decision tree. So you identify the data types for your hypothesis, if it's categorical versus continuous, which we had if we're looking at categorical, whether they're a heart failure patient or a control. That's categorical, right? It's nominal, yes or no. And age, that's continuous. Number of groups, we've got two groups. And if it's more than that, we would, figure we could use a parametric test. If it's two groups, then we use a t-test. If it's more than two groups, then we use an ANOVA. So you can use either way. And in fact, I have some stat pages that you can go to that if you just tell them, here's my independent variable and here's the data type, they'll tell you what stat test to use. It's not that hard. Okay, everybody makes this big mystery out of stat tests, but you know, you don't have a whole lot of selection. Okay? So then once you select your appropriate stat tests, hypothesis, is there a difference in age between the heart failure controls? We already said that. Age is continuous. The subject type is nominal categorical. How many groups? You have two. And again, we go down along here. There's two groups. We end up with a t-test. Now, I also have on the opposite side of the Wu statistical tree, there is actually the non-parametric test. So say that you had age, but you found out that age was not normally distributed. And whether when you graph it out, instead of being that nice symmetrical bell-shaped curve, it's all over the place, then it's probably better for you to use a non-parametric test. And for example, say we did the same thing. So Okay, so what happens if your data is non-normally distributed? You back it up into an ordinal data type. So instead of saying we have nominal and continuous, we have nominal and ordinal now. Okay, because age is non-normally distributed. So then we'd say we have nominal versus ordinal data. We have two groups. So that would be Mann-Whitney-U, median test, or Wilcoxon-signed rank test. And all of the standard stat packages, even Excel will do this. Okay? Now, we've talked about why type. Now remember, you need to avoid type 3 error. Type 1 error is basically when you claim there is a difference when in fact there really isn't one. It's a false positive. And your p-value, when you run statistical analysis tests, the p-value is telling you what is your risk for making a type 1 error. Okay, so the infamous thing is always p of 0.05. There is nothing sacred about a p of 0.05. It depends on where is it more critical to make the error. Is it more error to say, oh, they have it when they really don't? Or is it better to make sure that you claim that they don't have it, but when they really do have it? Okay, I think the infamous example is AIDS. You know, well, it's terrible to be you're told that you have AIDS, but you really don't. What is more dangerous? To panic the person and tell them they have AIDS and then find out with a more sophisticated test that they don't? In other words, is it better for you to do a false positive? Or is it more dangerous for you to do a false negative where you tell them, oh, no, you don't have AIDS, but in fact they really do? Okay? In this case, I think we'd be more paranoid about doing the false negative, right? So we would say, oh, okay, let's make it easier. Remember, the false positive and negative, type 1 versus type 2 errors, think of it like a teeter-totter. As your risk for one goes up, the risk for the other one goes down. Okay? Because you can't say that they're a false positive and a false negative at the same time. The only way that you can decrease your risk for both types of error is to increase your sample size. Okay? So type 1 error is the false positive, and your risk for that is the p-value, also known as the alpha error, and that is traditionally set at 0.05, but I have to emphasize to you, there's nothing sacred about 0.05. If you feel from your clinical judgment that you would rather err on the side of making a false positive thing, then you would raise that p-value. Instead of a p-level of 0.05, you'll say, 0.1 or something like that, right? However, if you feel that it's really, really bad if you make a false positive statement, you need to make it harder to say that they're significant. So you might go to 0.001. Okay? There's something called a Bonferroni correction, which will adjust the p-level, in other words, your risk of doing a type 1, depending on the number of samples or number of tests you do. Remember, a p of 0.05, all that means is that 5 out of 100 times you will get those results just by chance. So that's not too bad if you're only going to run 2 or 3 stat tests, right? But what if you're running, and I'm not kidding you, I had one of our faculty come to me, and she was running on 12 subjects, 150 tests. Yeah, I know, I nearly fell over, okay? With that, I mean, you know darn well that 10 of them are going to be, at least 10 of them are going to be have a false positive. And out of all of those 150, and I am not exaggerating the number of stat tests, I was a master's student at the time, and even then I was thinking, oh, this is a bad idea. And she only had 5 of her tests out of the 150 were significant. She said, oh, this is so great. Oh, we can change practice with this. And I'm sitting here going like, I don't think so. Does that make sense? So there's nothing sacred of a p of 0.05. And the more statistical tests you run, the greater risk you run of getting a false positive. Okay? Now, a type 2 error is when you claim there isn't a difference, but there really is one, false negative. So again, type 1 error is the p-value, but type 2 error, where you're doing a false negative, is in fact what your power analysis is designed to identify. What is the minimum number of subjects you need? The power analysis will tell you what's the minimum number of subjects you need to avoid a type 2 error. And we're saying, oh, there's no difference, when in fact there really is. But there's another type of error that we need to consider, particularly in this day and age of computerized stat programs and stuff like that. And that's the type 3 error, when you have the right answer but to the wrong question. So basically you apply the wrong statistical tests to your data. One of my favorite examples of this is one of the cardiac fellows. He came to me, and because the cardiac fellows, or like most of the people in these fellowship programs, they have to have a publication before they can get their certificate, right, before they can be certified. So this guy came to me and he said, oh my God, oh Mary, I'm so happy. I just sent off my first paper and, I got statistically significant differences. I said, oh, congratulations. And I said, so what did you do? And he was looking at the impact of these, like 18 different drugs on the atherosclerotic plaque on pig aortic valve tissue. And I go, oh, how many pig aortas did you have? And he said 6. I go, you did 18 drugs on these 6 different things? And I said, and you got statistical significance? I went, wow, that must have been a really big effect size. And he said, and so I asked him, well, what stat test did you use? And he said, I used the p-test. I'm going, p-test? What's that? And it turns out that somebody had put into their Excel spreadsheet, you put a number here and you put a number there, and it gives you a p-value. So he called it a p-test. Obviously, there's no such thing as a p-test. And number 2, obviously his data was not designed for that kind of stat test. It was probably more like a chi-square or something. Okay? So I said, you have got to get, so I ran his data, and it came nowhere near being significant. Right? So I said, you have got to grab that manuscript back. Get out of the mailer slipping. Unfortunately, it already went. He got ripped apart by the reviewers because it was obviously wrong, and everybody's going, what the heck is a p-test? Okay? So he made a type 3 error. And that is one of the great dangers nowadays. In fact, there was an editorial in Chest some years ago where they said, computerized statistical analysis packages have provided researchers with unparalleled opportunities to apply statistics incorrectly. And that's a type 3 error. Okay? So why do you need a power analysis? To determine or estimate how many subjects you need to minimize your risk for a type 2 error. And you only need it if you do not reach statistical significance. So, for example, one time I had some statisticians come out and tell me, Mary, you need 4,000 subjects. And I'm going, well, I have pilot data on 40 and I reached statistical significance. Well, according to the power analysis, you need X. Remember, if you found statistical significance, you are not making a type 2 error. In other words, you're not saying it's a false negative. I got a positive. Now, my data may have been wrong for other reasons, like I could have had a skewed sample or unrepresentative sample, right? But I definitely did not make a type 2 error. All right? So if you find statistical significance, who cares what the power analysis says, right? However, one of the big red markers that should come up in your mind when you're reading statistics or when you're reading research or when you're doing your own is if you find no difference. That's when you actually say, guess what? I need to see the power analysis. Because it could be one reason that they didn't find any significant differences. Maybe there really isn't any difference. But equally likely is that they didn't find any difference because they didn't have a big enough sample size. Okay? So in order to answer these kinds of doubts and queries, if you don't find significance, you need to run a power analysis. Okay? Or, for example, if you did did not find statistical significance, and you'd run a priori, for the study, a power analysis, say, hey, this is how many subjects I needed to detect this kind of effect size. Then again, you're going to be much more believable. Okay? So to perform a power, you need the following information. You need what kind of stat test you're going to run. You need to know what is the p-value or alpha. In other words, like I said, a lot of people use 0.05, but you can use whatever you think is clinically appropriate, right? You need a power. What is the risk of type 2 error, beta? Traditionally, that is 0.8. Okay, now again, there's just like with 0.05, there's nothing sacred about 0.8. And in fact, if you talk to a lot of statisticians, they'll say, oh, the power should be 1 minus the p-value. And I'm kind of going, if you look at most of the power analyses, they use 0.8. And, after, 45 grants in our group, and we're using 0.8 as a power, I think we're okay, all right? What is the effect size? In other words, what kind of difference do you want to be able to detect between the groups? And one-tailed versus two-tailed tests. And I'll explain about the effect size and one-tailed versus two-tailed in a few minutes. Now, there's a variety of ways of getting a power analysis. A biostatistician. And now remember, just because someone calls themselves a biostatistician doesn't mean they really are a biostatistician. Okay? A biostatistician has very, very specific training. And for example, at another Southern California facility, which will remain nameless. For example, I was sitting around there talking to this person, so I'm the biostatistician for this place, and he was saying the most wonky things, and I'm kind of going like, where did you get your degree? And it turns out he had gotten his degree in engineering from an institution who I do not have a whole lot of respect for. So it's like red and gold, and it's got anyway. But he really had no biostatistics training or certification. But he was, I think, one of the big hints to you about whether or not someone's a good biostatistician or not is, number one, they should not be holding your data hostage. Okay, this guy, for example, would say, oh, these physicians and nurses, they're too stupid to be able to understand these really high-level statistics. And I'm kind of going, a chi-square, give me a break. Okay? And so, number one, a biostatistician should be able to help guide you on what are the appropriate tests, and even better yet, to explain why they've selected certain tests or analyses, right? But remember, a biostatistician or any statistician is not a mind reader. You need to provide them with sufficient information about what, it may be articles on that patient population with those variables, so they can get an idea of what kind of effect size, what kind of data, and, you tell them what kind of instrument are you using. Okay, they can't just simply wave a wand and get these numbers. You need to provide them with adequate information, right? So one way of getting a power analysis is to go to the biostatistician. There are a ton. I'm always stunned at how many internet sites, including here at UCLA, actually will help you select the statistical test and actually run the power analysis for you. Now, admittedly, it's crude, but it's a pretty good beginning. And also there's software. For example, here at UCLA, we actually have a site license with SPSS and SAS, and they all have their own power analysis software where if your department has a license with UCLA Software Central, you can get access not only to SPSS and SAS, but also, for example, to the SPSS power analysis software known as Sample Power. Or, for example, we also have a contract with S+. Now, that's all very well, but for example, say your department doesn't have it, or because it's several thousands of dollars to purchase these things, which I always think is kind of insulting. Okay? So to tell you the truth, I advocate GPower. GPower is a lovely group of software that the people from University of Kentucky introduced me to, and it's free. They only ask that you cite them in your publications if you use it. Now, this is a group of people in the psych department who wrote this in Dusseldorf, Germany. And of course, they have a lovely German version, but even better yet, they have a great English version. And they finally have online tutorials and a manual. Can you imagine that? They actually have a manual in English as well as examples for you to run. Okay? So while SPSS sample power is nice, I think GPower is much easier to run, and it has that lovely extra added value of being free. So effect size, this is how big of a difference you expect to see between your groups. Okay? Now, for example, the number of cases so along the x-axis and your power along the y. So the more you get, as you get more and more or larger sample sizes, the power of your power analysis increases. And remember, you're trying to aim for a 0.8, right? Now, statisticians hate Cohen's terminology for effect size. Cohen actually wrote this absolutely lovely book on statistical power analysis for the behavioral sciences. And the only person I've ever seen with this book, the original book, was actually one of our former deans, Marie Cowan. This thing was falling apart and everything else like that, but she still had it. It was a lovely thing. And like I said, statisticians hate this, but I find it very, very useful when you're explaining, when you're talking about how big of a size are we talking about. So Cohen is the one who basically said there's a large effect size versus a medium versus a small effect size. And so he'll say, okay, a small effect size is like, would be for like a t-test would be 0.2, then you only need about 58 subjects and the like. So Cohen is the one who put out the term small, medium, large effect sizes, and these will vary according to what statistical test you use. Now, remember, I also talked about the fact that you need to figure out whether or not it's one-tailed or two-tailed. By tradition, you should always go for a two-tailed test, but because that looks at both sides. Tails, these little things at the end of the bell-shaped curve, these are known as tails, okay? Now, on a two-tailed test, you're basically looking at both if something is higher or lower. On a one-tailed test, you're just looking at one side, at one tail, okay? Now, why would anybody want to do a two-tailed test? Well, one of the big hints, if you see that someone's doing a two-tailed test, is because they could not get statistical significance on a two-tailed test. A one-tailed test requires fewer subjects, and it's easier to get statistical significance. Okay? So every time you see a one-tailed test, the number one knee-jerk reaction should be, they didn't have enough subjects. They did not find statistical significance. So when in doubt, try and run a two-tailed test. However, as part of grantsmanship, sometimes you run a one-tailed test just because you want that p-value to be significant. Okay? So just to let you know. Now, examples for running a power analysis. So I'm going to talk about using GPower free. Here's where it's available from. Or you could just Google the term GPower and it'll come up there. Again, sample power is free if you have SPSS from the university. Ask your IT to install on your computer. And also, UCLA has the interactive statistical calculation pages, which have things like we'll run various stat tests for you, t-test, chi-square, ANOVA, and the like. You just have to enter the data, as well as power analyses. Okay, what do you write in your grant? So basically, you tell them using what kind of stat tests, how big of a sample, right? Would allow detection of moderate, and I say how big of an effect size. At an alpha, that's p-value of 0.05 and power of 0.8. The greater the effect size, the bigger the change you expect, or the bigger the difference between the groups, the smaller the sample size you usually need. Okay, so if I run a stat test and then run a post-hoc power analysis, in other words, that's after I've already collected the data. So, for example, is there a difference in age here? And this is just one of my data sets. So I ran an independent samples t-test at SPSS. By the way, are you guys aware of the fact that as UCLA staff that you have access to something called lynda.com? Lynda.com is actually these online tutorial pages, and they actually have a tutorial on SPSS and SAS. So if you're, SAS and SPSS are wonderful stat packages. Also, believe it or not, you can run a lot of simple statistics on Excel. Now, a lot of statisticians will go around and say, oh, Excel, you can't, it's not as good as the regular stat packages. I got news for you. I ran the same data on SPSS and Excel, and that was for a 5,000 data set of heart failure patients here from UCLA. And, I got the same answers. So I would not say poo-poo for Excel. Why? It's because guess what? Everybody has Excel. SPSS is hard to get a hold of. Okay? So you can always run preliminary studies on Excel. So anyway, so when I ran these t-tests, I got my means and my standard deviations for each group, and you would look at that and going, oh, I don't know. That doesn't look like and this P, it's not significant, right? So if I got this P value, and remember, look, I only had 32 and 16 subjects. That's not very many. That's what, 48? Not many subjects, right? So should I toss out this thing? Oh, there's no difference? No, it may be because I did not have enough subjects. So let me run a power analysis. So I say, okay, remember, I want a two-tailed. Effect size, I'd say, oh, let me see. I'm only going to like it if I can get a large effect size between these things. And actually, this is a medium effect size. This isn't large. This is on a t-test. Here I told them I have 32 and 16 subjects. And then look, so here's my power. My power was only 3.359. Now remember, we want it to be 0.8, so obviously the reason why I did not get statistical significance is not because there isn't any difference between the groups. It's because I did not have enough power. I didn't have enough sample. Does that make sense? So as soon as you run one of these things on your pre-existing data and you're kind of going, my power was nowhere near 0.8, I'm going, guess what? My sample size was way too small. So then I click on, let's determine how many subjects I would really need. So I enter in that I want to, again, do a t-test. I put in the means for each group. I calculate it. And again, my effect size in this case is 0.271. This is for another example. This is, in this case, this is on, this is again on a t-test. So again, very small sample size. And again, if you want to use Cohen's definitions for small, medium, and large effect sizes, all you have to do is mouse over this area, this effect size over, and this little window will pop up. So let's figure out what is the optimal sample size for this hypothesis to avoid a type 2 error. So that elastic effect size, we put in 0.271. We have a P of 0.05, power of 0.8. If we hit that, we need 430 subjects. Do you think I'm going to be doing that study real soon? No. So now I can go off and have a Dr. Pepper. Okay? Because now I know this is going to be a ridiculous sample size for me to get within my lifetime. Okay? Now on some studies, 430 think, oh man, I can get that in a year. That's not that big of a deal. But in my case, where they cannot have any metal in them, they have to be able to lay flat, they have to be between the age of 40 and 60, they can't have anything else wrong with them, that's going to take me my lifetime to get that many. Okay? And most NIH grants are 4 to 5 years. Okay, what if I wanted an estimate of a needed sample for a large, a 0.8 effect size? Remember that previous slide was for a small, a 0.27 effect size. That's pretty small, right? But a lot of my effect sizes are in fact gigantor. Okay, so let me go be quote unquote conservative and go for a large effect size. Well, if I did that, then guess what? If I go for a large effect size, everything else is the same, I only need 52 subjects. What do you think I'm going to pick? Okay, should I go for being able to detect small effect sizes difference between the groups and therefore need 430 subjects? Or should I say, I'm going to go for hypothesis and variables in which there's large differences between the groups? I think I'm going to go for the study that has large differences between the groups. And then I only need 52 subjects. Okay, so again, there's lots of different ways that you can get GPower. It's free. It's on the Mac as well as the PC. There's also at UCSF, they have a great stat analysis group that gives you lots of resources in terms of what is ANOVA, how to pick out stat tests. They'll run simple statistics for you as well on their website. And of course, good old UCLA, these are a wonderful group of people. And remember, I think it's Thursdays, every Thursday afternoon, that the division over at Public Health of their biostats group will actually have free consult hours. And also remember, there is a reason why there's a School of Nursing on this campus, and you guys are part of our family, right? Remember, I'm one of you. Okay? Don't feel shy. Give me a call. Sometimes the best way to figure out these things or to use the software is just to sit down with somebody and do it. Because, I can go ahead and show you all the little slides you want. But, sometimes, you're sitting there and you're looking at that software and you're going, this does not make any sense at all. And so feel free to give me a call. It's not like I have a life. Okay? And next, remember, we have a great group of statisticians, and both Priscilla Kehoe, who's back here in the back, and Addie Nyamathi, pros. Not only pros at statistical analyses, but superwomen when it comes to editing and getting grants and manuscripts back. I always remember emailing Addie in particular at 3 a.m., and all of a sudden I get a reply back. I'm going, doesn't this woman ever sleep? Okay, and she always gets me the stuff back, and I have to admit, I just hate her because she's always so friggin' perfect. She's so nice about this and saying, oh, Mary, this is such a lovely attempt. And then, I'm going oh, my God, got to rewrite this whole thing. So, I mean, again, remember, we are there to help you, and we've had a lot of experience at that. There's a lot of resources both on this campus and in the School of Nursing that can help you. If you have any questions at all, please give Priscilla, Addie, or myself a call, and we just walk down the hill and have a great time. Okay? Thank you.
Thank you, Dr. Wu, for an amazing presentation. We'll take this moment for questions and answers. Any questions? Santa Monica as well.
Hi, my name is Rebecca Lash.
Can we get a copy of the slides?
Oh, yeah. As I recall, they are going to have, I gave them permission to create PDFs of the slides. And if you like, I can just re-record this in Camtasia, which will basically synchronize the audio and a video presentation.
Yes, please.
Of note, the presentation is posted on the website. I'll show you in just a moment where it's located. And we'll also have a recording of this also, so you can go back and enjoy it again.
Yes, over and over again. I know a lot of my students say they go to sleep with my voice droning in their ears, which I find kind of frightening myself, but...
I'm a former student of Dr. Wu, actually. Quick question. You mentioned the no sacred value 0.05, and I think that gets ingrained in a lot of people. In terms of publication, have you ever published anything with something that's, you say 0.1 or 0.08 or something, and how do you address that in your publication?
I have to actually change my p-value a lot because of my research in brain MRI. In brain MRI, we go by voxels, and I usually go by a 0.8 by 0.8 by 0.8 cubic millimeter little cube per voxel. Now, for each region of interest, for example, the mammary bodies are a relatively small region of the brain. There's these small little itty bitty things at the bottom of the brain. And those can go for thousands of voxels. Now, when you're doing a group analysis, running t-tests on, a few thousand t-tests, if you don't change that p-value, you're going to get a bunch of values or tests significant just by chance. So I very often have to do a Bonferroni correction. I usually have to go down to 0.001 on my p-value. Again, because the more statistical tests you run, and the rule of thumb, you can go ahead and do a Bonferroni. Quite fortunately, when I run these tests, the software that I use to run the analyses actually does a corrected p-value for me, and it calculates it out. So it makes my life so much easier. And there are lovely, lovely formulas that you could take a few weeks to run to figure out how to change your p-value. But the rule of thumb for every 10 statistical tests, you should add another 0 onto that p-value in order to make it harder to reach that statistical significance level.
My question is more of you trying to explain the other way why 0.08 was acceptable in this case. I know you're not terminology approaching statistical significance. Yes.
As you know from my from one of my rants in your class is, I hate it when people say it's approaching statistical analysis. It kind of reminds me of like you're approaching pregnancy. But what does that mean? So I have had to do that, and have seen it done very frequently, where it is more terrifying to have a false negative than it is to have false positive. And the classic examples are an AIDS test. So if you look at just about all of the publications about AIDS tests and how sensitive or specific they are, all their p-values are a lot easier to reach than 0.05.
Are there any other questions? Don't be shy.
Excuse my voice, I obviously got a cold, but it's not so much a question as a comment. Thank you so much. This has been such a big help for a lot of us who remember statistics from many, many years ago.
I know, same with me, man. I remember Donna Vrado was saying, now we're going to talk about t-tests. I'm going, you mean like that little t-square that you put on top of paper? It's like, unless you use it, it makes no sense. But remember, you're less than a block away from a group of people who have to live and breathe it.
And that's such a nice offer, because you're likely to get lots of people lining up.
Yeah. I mean, like, why not? And like I said, it's not like I got a life. Addie and Priscilla know. Okay? I'm hanging out there doing my MRIs, and that's what it is.
Quick question. I'm Julie from Cardiac Arrhythmia Center. So, yes, I know. The PI-initiated trials, like non-funded, it seems like we're always calling everything a pilot study to avoid. I know, and I know you said you did a pilot of 40 or something. So
no, actually, my famous example is Marie Cowan, who got a $500,000 a year R01 grant with 5 subjects. Okay, but that's where grantsmanship comes in. That's where some people like Priscilla and Addie can really, really help you. They have helped me on all of my grants because, to do a grant, you have to sit down there and get an idea. You can't just say, wake up and go, I think I want to write a grant today. No, I mean, it's a lot of work. So why not take some of that burden off for people like, I always want to grow up to be Addie because, she writes so beautifully and she's so successful in funding. When you have someone like that who's that successful all the time, makes me sick, but that's okay. The thing is that writing a grant is both an art and a science. There's a lot of things that people never tell you, and that someone like Addie can sit down and say, well, here's how you would plan it out. Here's the kind of stuff you need before you go for this kind of funding. Okay. Yeah, Eddie.
So I wanted to take a moment and remind both Ronald Reagan and Santa Monica folks that Pamela and Priscilla and I are going to run a meeting tomorrow between 9 to 11 at 8-2 level, and it's going to be an opportunity for all of you clinicians and faculty to get together with matching topics and work together, and we can work on grants and utilize statistical support in the School of Nursing, and it'll be a very exciting opportunity. Pamela's already given us a huge list of many people that are coming, so I just wanted to make sure you all knew about it as well.
Yeah, I have to apologize here. I really, really, really wanted to be that, but I'll be flapping my wings off to Duke University tomorrow, which I'm not really happy about doing because they had asked me a year ago to present some of my research as well as do some consults on some of their projects. So I apologize for that. I'm going to be away, of course, that one day. So, but remember, I'm only an email away. Right? I'm here on weekends and holidays doing my MRIs. So if you want to, we can meet any day and time. All right?
This is more a general question, kind of going off of what you said with the pilot studies and whatnot. In neurosurgery, we're doing a lot of telehealth visits now with post-operative patients and whatnot, and so it's a prospective study, but the N is not going to be enormous, because the neurosurgeon I work with, sometimes they're 8, 12, 16-hour cases. You don't have high volume each week. So I'm being somewhat pressured to use historical controls in the comparison study, which I do see merit with that and worth with it. Obviously there would be a higher yield of doing, randomized study, but I would be doing this for 10 years to get the number that would make sense to do that. So
I would actually, that's probably a good place to start is with either a historical sample completely or with a historical control. And the queen of those clinical grants is Addie.
Well,
so I think, what you need to do is, grab some of that data, figure out what are the important clinical outcomes. How big of a difference do you see? For example, we're just writing a grant with Nancy Pike, one of our currently assistant, but hopefully very soon associate professors. And I'm going, oh, guess what? With 9 subjects, she's seeing gigantic, statistically significant differences. That's a huge effect size. If she's finding differences between these groups with only 9 subjects, 5 of the controls and 4 congenital heart disease kids, how big of a sample size do you need? On some of her stat tests, I'm going, okay, you need 10. That's kind of embarrassing, right? So if you take a look at your data and identify what you feel are really important outcome variables, like I said, I would go for what I call the low-hanging fruit. I go for the ones where if you do the power analysis, you need the small sample size.
Okay.
And we love writing stats. It's so much fun. And to tell the truth, I have a lot of undergraduates who work with me who have not had stats yet and who, most of them are pre-med or something like that. And I have some of the undergraduate nursing students as well who don't know statistics, and I teach them statistics in half a day. I know that you're a lot smarter than they are, and it would be no problem to teach you after a few hours. You could do your own statistical analyses. You pick. I do it in Excel as well as SPSS. So not that hard, trust me.
Any additional questions? Santa Monica?
They're muted.
We're here. No, we're good. Thank you.
Okay.
Thank you for
But
an
remember, I
excellent
love Santa Monica. So give me a call at any time. I love going over there.
Okay.
Particularly
we
with the
will.
shuttle.
Dr. Wu.
Okay.
Oh, it's fun.